So once, you know, can't teach an old dog new tricks, but.
We could have the students practice on your shoulder.
Yes, we'll do that too. What's this? I don't know if Denise had any other announcements, or was that what she needed to get from you? Okay. Are you all set then? All right. Well, welcome to your NPTE review extravaganza. These activities that I'll do with you today are things that we've been doing in our school in Ohio, which is a sister school of this school. So a little bit about why I'm standing here. I'm a physical therapist. I'm an old bachelor degree, 1991 grad from Bowling Green State University in the Medical College of Ohio. And I started practicing in a variety of settings: acute care, home health, outpatient clinics, pain, pediatrics. And then I was running my own little contract company for a while, and someone gave me a call and said, hey, I got your name and number from someone who thought you might be available on Tuesdays and Thursdays to teach a class for a PTA program. And I go, well, my Tuesdays, yep.
8 and 2 minutes.
Perfect. My Tuesdays, Thursdays just opened up because one of the nursing homes I was contracted with no longer needed my services. So I'm like, okay,
go to YouTube,
what do you got?
And look up Taylor.
So I drove to this PTA
Taylor
program, and I met with the director, and she gave me a crate, two crates,
and I don't want it on the
full of
well,
stuff.
I guess it doesn't matter.
I think Tim can probably relate to this, having just picked up new courses, right? And she's like, this is the course you're going to teach. And I'm like, it was musculoskeletal, which was basically orthopedic. What you got? Right? So I drove to this PTA program, and I met with the director, and she gave me a, because when you're done, I need you to put this all together.
I don't want it on the
well, I guess it doesn't matter. I think Tim, because it wasn't organized that way. So I went out to my courses, right? And she's like, this is the course you're going to teach. And I'm like, it was musculoskeletal, which was basically, now I had, so I drove to this PTA program, and I met by the end of it, quarter, because when you're done, I need you to, I had 2 crates.
I don't want it on the
pregnant, had a baby, and the other one, I don't know where she went. But 3 of them finished and graduated. But halfway through that class, they said, Deanna, what are we supposed to be doing with this other textbook that we have for this class? I go, what other textbook? And I think it was the Kistner-Colby. And I said, well, we're doing fine with the one we're using, so let's just stick with the one we're using. I was such a horrible teacher. I didn't know what I was doing. But thankfully, the students did okay. That was in 2003. And then I started picking up more and more classes, and I went full-time in 2010 as the program director. But to do that, I had to go back to school. I got my master's degree in counseling. By that time, Denise had already stepped in as the full-time clinical director, so she was already taking care of the clinicals. We had met out in the field. And so from 2010 to 2023, I was the program director. Meanwhile, finished my PhD in higher ed education, leadership and policy, whatever that means. And so then in 2023, Denise then took over the program as the program director. And so I stepped into a corporate role that I do now for the various schools that we have as the academic director. But in the meanwhile, I have taught the capstone, like what you're in, you know, that final class. And just by trial and error, and more error on my part than trial, tried to figure out what is the rhythm that students need at this point in your education to try to get through this one last test, right? And so it really boils down to taking everything that your instructors have poured in and everything you have done through blood, sweat, and tears and go, but how do I make this make sense, okay? And so we have to fit into the mold that's been set for you, which is a 140 question exam with a 3-hour limit on a set date that you have to sit and take. Doesn't matter how good you are and how skillful you are with your hands. It doesn't matter what your clinical instructors rated you. Doesn't matter what score you got in your fundamentals class. What matters is these 140 questions and the 40 practice questions that you don't know which ones of those are on the test that don't even count. So don't stress. The one you don't know might not even count. And we just have to get you to fit into their mold, okay? So this is a little bit of an unorthodox review session. So I'm hoping Dr. Lisa doesn't judge me too deeply on the way that I will present the material, because it will not be as refined as how she has presented it to you, okay? And so we've divided the day into these little categories that I think would be good takeaways. And this is being recorded, so you can go back to this and review. You do have a little time between now and your exam. And so we will be talking throughout the day of strategies we have put into place to make sure that you cross the finish line in first place, okay? With getting your license on time and getting into the career that you want to do, okay? So any questions about the purpose of today or the structure of today? You will be exhausted. I'll be exhausted. I wore my comfy clothes. But I think you'll come away with enough that you can look at that and go, okay, now what do I need to do to get through this? There is no review test that's going to get this ready for you. You just have to study and read the books. Every test question on the NPTE is rooted in a textbook and cited in a textbook. But you haven't used every textbook that will be cited on that test. No program has. So there will be questions and words you have never seen before. There's no way to avoid that. So don't get tied up on that, okay? There will be language that you're not used to seeing because some of the ways that we talk about it here might be a little different than how they talk about it in California or Michigan. Okay, up in Ohio, the Michigan area, Dr. Gary Gray lives up there. We're very Dr. Grayish in that area in the Midwest, right? Have you heard of Dr. Gary Gray? Okay, so he was like pivotal in the world of physical therapy 20 years ago when we finally realized that the closed chain mechanics of the foot actually impacted the rest of the body. And he had this landmark program called When the Foot Hits the Ground, Everything Changes. So you guys have never even heard of Gary Gray, but we're like all Gary Gray up there. So regionally, sometimes we talk different in regions of the country. So for that test, there's going to be words you're like, oh, we didn't say it that way. You're going to have to be able to figure out what were they saying. Okay, does that make sense? So you have to be really flexible in even reading. Welcome, welcome. I'm so glad you guys could make it. Buckle up. We're going to have a great day.
So the way it works, it's 100 and then 40 could be
No, 140 counts. It used to be 150.
And then how many are
and
like
40 more. So you probably answer 180 questions. It used to be 150 and 3 sections of 50. Four sections, 50 extra questions. But nonetheless, some questions are beta questions.
Okay.
Yeah. And these questions are so analyzed, okay? And we'll talk about basic test-taking strategies as we go on, okay? Especially when we get into some of the kinesiology stuff. How many of you struggle with kinesiology questions? You're like, oh, like I was totally backwards on that question. Like I didn't realize where gravity was or whatever. Yeah. And so that's the secret is first just know what you're reading. Yeah. You all know enough to pass this test. You've all learned enough. We just have to get everything you know on that test. And the stuff you don't know won't be enough to fail you. But if you can't get what you know on the test because the test itself freaks you out, then we can't test what you know. We need, as they say, leave it all in the field. So we need what you know. The ones that you should get right, we need you to get those right. We don't need to make stupid mistakes. That way the ones that you don't know won't hurt you. Does that make sense? We just need enough, 600 points. However that's calculated. Some questions are worth more than other questions, right? Knowing the origin of a muscle is going to be like smaller points than knowing the intervention you're going to do for a certain phase of healing of an injured body part, knowing from the description. So it's weighted, scaled differently. The way those statisticians do things, way smarter than myself, okay? All right, let's jump into what I call systems man. And I need a volunteer who's willing to stand up here and have various things. Thank you, Andrew, for volunteering. So actually, I'm going to have Andrew stand up here if you don't mind. You can, shoes or no shoes, I don't care. I'll be up there all day. Okay, this is Andrew. Andrew is going to represent to you the comprehensive nature of your patient. Now, unfortunately, in school, we don't get to really address the patient this way until the very end because we have to break it up into systems. Like, okay, we're going to talk about the cardiac system, and we're going to talk about the orthopedics and the skeletal system, and we're going to talk about the pulmonary system, right? And so the truth is, your person actually has all the systems, but we have artificially dismembered them, haven't we, within your curriculum? And you're trying to figure out how does a knee replacement even relate to congestive heart failure, right? And it's like, but they do. And guess what is be on your test? Questions to make sure that you know as the licensed person in the clinic that the patient diagnosis that you're treating is a person that has everything going on, and would you recognize an emergency if it happened? Would you recognize a reaction to treatment that's not normal? It's all safety. It's all safety. So when you're reading a question, you're like, what are they trying to get me to answer? Okay? So if they're asking you a question about low back pain on this patient and whether it hurts if they flex or extend, and then they tell you the patient is a 12-year-old gymnast, what little red flag goes off? Like, oh, I know what they're getting at, compared to an 85-year-old gentleman. So what do you think if they mention 12-year-old gymnast? What assumptions go through your head? Because it's safe to assume here. What about her range of motion? She's probably hyper. Which way? But which way more than the average bear? What does a gymnast do that's freaky?
Oh, like
Yeah. What condition might a gymnast have that nobody else in this room probably is going to have? What is that one called? What's the first letter? Do they know this one? It's an S.
yeah.
Spondylolisthesis. You're like, oh, so in a general question, you're like, I know what they're getting at. I know what they're getting at. This young lady is probably hypermobile in the extension, and she could have a fracture causing that low back pain. Is she going to have spinal stenosis? No. That's old people. Okay? All right. So, oops, sorry, I just hit that. So this is systems man. So let's take a typical diagnosis that you learn early on in your curriculum, a total knee. We're going to tape that to his knee. Okay. Now, every patient has every system. So he also has a cardiac system. So this patient who's coming in for his total knee also has a little hypertension going on. And you notice, obviously, one of his conditions that the PT diagnosed him with might be weakness, and that's going to be obviously in the knee muscles. Okay. And then in the chart, you read a few other things, and you notice that he, well, just by looking at him, maybe he's just got a little extra on the tummy there. Okay, let's go ahead and stand out there. So now you have this patient who doesn't just walk in with a total knee, which is from what diagnosis usually triggers a total knee replacement? Osteoarthritis, right? All right. Now, what if he had, what if he also had rheumatoid arthritis? Because they get knee replacements too. Let's put this up here because it's a systematic problem. Okay. Now, how does your approach to this patient look different than your approach if I walked in with my knee replacement? Okay. So now what this test is trying to get at is, do you know how to manage this patient in the room and delegate to your aides and know what you're looking for? Okay. So for this guy, tell me some things that you can assume about him that you're going to see if you apply a normal total knee replacement protocol to him. What are some things that are going through your mind? And you will be called on. So this is a safe place. If you totally botch it, that's okay. We're here to row the boat together, okay? Raul? Trunk control?
Yeah.
Why?
I mean, if obesity, maybe morbid.
So what is he lacking in
plus
trunk
increasing
control?
the aspiration as well on that knee.
Okay.
No weight bearing as well at the moment, depending to doctor's orders, partial.
Mhm.
That's what just things that just go through my mind at that time.
Okay. Most total knees, unless your surgeons regionally don't, but it should be full weight bearing. Okay, yeah.
Fatigue.
Why fatigue?
Rheumatoid arthritis, that's one of the biggest symptoms. You don't want to overwork them.
Okay, so you've got him in your clinic next to me in your clinic, and we both have total knee. How will our treatments look different?
You can do more strengthening.
They're going to be different, right? And the licensing exam is intended to make sure you can weed out the difference, because a family member, an untrained person, can take him through his exercises at home if you teach them. If you teach the wife his exercises or a child, you know, the son or daughter, and say, hey, this is how you do dad's exercises. A family member can do that. A nursing assistant can do that. What they can't do is differentiate a different person with that diagnosis with their comorbidities and their complications. Does that make sense? So for his exercise protocol, what else? What assumptions jump in your head? What words jump in your head when you see him? Whether it's data collection, what is it? Oh, now we're doing vital sign monitoring. Did you automatically assume that for me? Maybe not, right? What else are you assuming with just these couple things? Yeah, right. So what types of dosages of exercise are you going to think about for him? Let's say he's, okay, let's take it one step further. He's day 3. So what types of exercises?
Perhaps we'll do pine first.
Okay, all right. Day 14, what are you going to do differently, Stephen?
More range of motion.
What should he be at day 14 with that knee? Assuming it was somewhat normal before.
It should be flex more.
How many? Give me a number.
Give it 40 degrees.
Oh God, please have more. Or I'm not even on the pot yet.
So,
What's this? What's this? What's this angle?
90 degrees.
Okay, and I'm a little blunt, and I'm teasing you, so please don't take me personal. Okay, okay. So if this is 90, and we know the surgeon is going to flip out until they get to 90, even though the real problem with a knee replacement isn't flexion, is it? It's extension. You guys are smart. Yes, it's always extension. You can live life with a little flexion, but you can't walk at all if you can't get that sucker extended. Excellent. Okay, so, but he has rheumatoid arthritis. So how are you going to know if 90 degrees on day 14 is on target for him, way behind, or wow, he's really cooking? How are you going to know expectations for him?
Of what he could have done before.
If there was a pre-op eval done, what if there was none in the chart? Beautiful, right? And maybe the question says that on this leg, he only has 80 degrees of flexion on a good day when the wind's blowing the right way, right? And so he's got 60 here, and it's day 14. Is there cause for alarm or reason to call the doctor? Guess what? You're going to get a lot of those questions. Is this response what you would expect for this patient? Now, if I'm at 60 degrees on day 14, there's a problem, right? If he's 60 degrees on day 14, that's okay. We're getting there. We're hobbling along with this guy. Okay? All right. Excellent. Thank you very much. You can take those off. We will call up a new volunteer and hit a different system. See, that wasn't painful at all. It didn't hurt. Nobody cried. Nobody bled. All right. So let's go with, oh, this will be a fun one.
Oh.
This will be a fun one.
A few more.
Okay. So thank you so much. Okay. So this guy, all right. So let's say you name a manual labor job that would be pretty cool to do. Let him answer for himself.
We're going to go for auto mechanic.
Auto mechanic it is? Okay, so we're going to put the herniated disc here because we can't see it if it's on your back. So he's got a herniated intervertebral disc. What motions are going to be painful for him? Early on, right? Anything's going to be painful early on, right? He's probably going to be all whopper jawed. All right, so let's say then you find out in his history he also has Crohn's disease. Oh, poor sucker. That's rough. What system is Crohn's disease? Gastrointestinal. We are not gastroenterologists, are we? Nor do we play one on TV. But what does that have anything to do with this intervertebral disc treatment? Let's say we're treating it conservatively and he has not had surgery, and you're just going to apply McKenzie extension exercise, right? You understand that you know that one? McKenzie goes with extension, Williams goes with flexion. And he's responding well based on his evaluation to the extension protocol. So you're doing extension, but he has Crohn's disease. What kind of assumptions jump in your head?
Pain.
What level? Abdominal pain?
This is what?
What level is his herniated disc?
Oh, let's go with 3. L3. Sorry, yeah. Lumbar. So what does Crohn's disease, how will that impact? He's working in with you in outpatient, typical outpatient clinic.
Lots of rest breaks, go to the bathroom.
Acid reflux or heartburn.
So let's start with the bathroom breaks. When will that make the most impact on your treatment? When do they not have an option for a bathroom break at will?
They do, but it just takes time.
What if he's hooked up to E-stim and a hot pack or traction or something? A little hard to get out of that. So, you know, that's just a practical application, okay? But let's go to the other one. Who else said something? What did you say?
I said acid reflux.
Acid reflux. How does that impact your treatment? Why does that matter for you?
Just makes it harder to gauge like where the patient's at.
Position. So what do you need to not do for him that you might do to the other person with the herniated disc next to him in the booth? No lying down flat? Do you have an angle? Is there an angle you would like to keep at, or one that is there a number? Because you know numbers are good to just have in your head rattling around. Just any kind of number. Maybe 45, maybe 30 would be enough. I don't know. What, 30, 45, something around there. Good, good, good. Let's say you also find out he does struggle a little bit with blood sugar. Let's see. Where's your pancreas? Okay. He's got a little bit of diabetes going on, right? So how does that impact his herniated disc recovery? Does it make it better or worse? Any other considerations? He's not on insulin, so we don't have to worry about that so much. Dizzy maybe? So you're at least going to be aware whether his sugar's spiking today or low. Okay. All right, good. Let's think of another comorbidity that could be going on with him that well, okay. Clearly we have pain. Let's talk about pain for a minute. How do we measure and document and objectify his pain? A visual analog scale, right? How does that affect his therapy and his relationship with you? What are you thinking about when he walks in for his visits with all this going on? Yeah, yeah. And you have to be careful. We're not judging him, because it's like if you were in that situation too. Okay. Good. So you see how a simple herniated disc changes things. So you're reading a question about doing exercises with this guy. These are listed in the question, that he's got Crohn's or maybe acid reflux, GERD, right? GERD, maybe some diabetes. And you're like, okay, but you've got these selections and you're like, I don't understand. None of these really have anything to do with intervertebral disc. Like, where's the extension exercises? What they're trying to get at is, do you know how to manage the uniqueness of him with his other things compared to what you know about treating a disc, right? Everybody knows flexion versus extension and all that. So sometimes they're trying to see if you can tease out bad tolerance to the exercise, right? If they say you're doing extension exercises with this guy and he complains of some of these symptoms you've talked about, what would be your response? They will always call the doctor, consult with the PT, continue the treatment as ordered, or stop treatment. The answer is not always call the doctor or consult with the PT. It might be continue treatment. Why? Because it's a normal response and it's a safe response. Or they might be asking, do you recognize there's a problem here and you need to stop? Right? So if he had a history of, let's say he had surgery. So we'll jump out of here. Let's go to let's take him from being a low back to a total hip. Okay, we'll put a total hip over there, yep. And he has no other conditions. And in the question, it says that he complains of sudden onset, severe shortness of breath. Why? More dangerous than that. Severe sudden onset of shortness of breath with someone with no pulmonary history, otherwise healthy. Yes, DVT that went where? To the lung. What do we call that? Pulmonary embolism. Okay? Why would we jump to that conclusion for him versus someone who has this in their chart? So maybe they have COPD. Okay? Welcome.
That's actually her last name.
That's right. You're welcome. I'm Deanna. Nice to meet you.
Sorry.
Yeah, I got you. I'm good to see you. All right. So for this gentleman with a total hip who's having some shortness of breath during treatment and he has COPD, you're going to address that differently. You're going to check his pulse ox. You're going to make sure that, he's not either, needing inhaler, right, treatments. That's going to be very different than the total hip patient who all of a sudden says, I can't catch my breath. And there's no history of that. Then what are you thinking? Okay. So when you're looking at these questions, you have to think whole person, and you're going to read the question like a test writer. Go ahead and have a seat. Thank you so much. You can take your hip off there. Thank you so much. You guys are very gracious. All right. So the moral of that story is, and we'll talk a little bit about addressing the comprehensive patient now in your question. The test writer is trying to ensure you can manage the safety of the clinic and the patient. So they're going to give you enough information to clue you in on what they're trying to get at. So they're not going to ask you, what is the protocol for a total hip? You're going to get done with the test and go, was that even a therapy test? Like, was that even a therapy test? Like, just ask me a good question about a fracture recovery protocol. Ask me some good closed chain stuff. I want to show you how I can, rehab a patient. No, they know you can do that. They know that a highly qualified PTA can do a lot of that stuff. You're the licensed person. Can you manage the unexpected? And do you know the unexpected before it happens? You already have to know what you're looking for. Does that make sense? So when you have these patients with all these conditions and they walk into your clinic, you have to actually do what we've told you all your life not to do. Stereotype them and make assumptions about them based on their diagnosis, because we need you to be ready to see that when it happens. Does that make sense? So if you come in and I know that you have insulin-dependent diabetes and it's 11:30 and you haven't eaten lunch, I'm already going to assume we're going to have some low sugar issues. Am I being mean by judging you? No, I'm trying to make sure that I'm managing you. So I'm going to have to predict and plan ahead for your medical needs. And that's what the test is about. Okay, so we have that patient that walks in and you're going to implement Lisa's plan of care, and they're starting on the new step. You guys use new steps in Florida? Okay, everybody should be on a new step. I've had people on there with one arm and one leg doing a new step, like literally double amputees. They can all get on there. It's a little tricky getting them on and off, but and so they're doing the new step. They're that total knee patient, but they have a pacemaker. Uh-oh, that's different than if I'm on the new step without a pacemaker. So in that question, they're going to give you enough information to let you know what little piece they're actually getting at. Do you understand the implications of a pacemaker on aerobic exercise? Like, oh, I know what they're asking. It has nothing to do with the total knee or the age of the patient. They have a pacemaker. That's the winning thing, pacemaker. And then they say the patient's pulse seems to not change from 74 beats per minute, despite being on the bike 10 minutes. Patient complains of feeling shortness of breath and very fatigued. What should you do? And your answers are, keep them going. They need to build their cardiopulmonary endurance. Stop the exercise immediately and call 911. Call the PT, or stop the exercise and let them rest. And you're like, I hate these questions. So if a patient is on the bike and they have a pacemaker, there are two kinds of pacemakers, to be overgeneralized. The ones that are steady state and the ones that are demand respondent, right? Some pacemakers only kick in if your heart drops below, like it's a backup. Others are steady state, like you're getting that no matter what. Like your pacemaker is your rhythm keeper. And let's say it's set at 74. What would you expect to happen during exercise in 10 minutes on the bike? What should your heart rate be doing? Going up. How much? Quite a bit to a target heart rate, right? Which would be, and all that. And we'll get into that with the grid in the vitals grid. Perfect. But this guy's at 74. So what do we know about someone whose heart rate cannot change? What is then our measure of intensity for exercise if heart rate can't be the thing because it won't change? RPE. One option is the Borg scale, right, which is the 60, 70, 80, 90. Take away the, add a 0 and, yeah, that one. Or 1 to 10. Subjective complaints, dyspnea rating, right? Blood pressure. How about pulse ox? So the appropriate response, hopefully one of the options is, check the other vitals, see how they're doing to see if you need to reduce the intensity of the exercise since they have a pacemaker that is set and won't allow their heart rate to increase. You see how it directed, like it gave it away. Like if they have a pacemaker, what's the problem here? And then you realize total knee had nothing to do with it. Does that make sense? Because how many of you have trouble going, I don't know what's important in the question, right? So I always suggest that you read the question like a test writer. So let's play that role. Let's say you are writing a course for new PT aides techs, and they will be helping in your total knee clinic. They are going to be the ones that get to count the quad sets and the ham sets and the glute sets for you. And if they take this little 20-hour class with you over the next 5 Saturdays and they pass their test, they get a $1 raise, and they're going to be like the lead PT tech for the orthopedic clinic with the PT and the PT assistant, okay? And so you're teaching them about Valsalva maneuver, which is what? Holding your breath. And who is that dangerous for? People with cardiac condition, right? High blood pressure. And you want to make sure that they understand about that. So let's write a test question for them. Give me one part of the question. Okay, try someone who's, but you don't want them to know what you're getting at.
A patient is holding their breath while lifting weights.
Okay. All right. And how do you know they're holding their breath?
Because they're not, their face gets like red and.
Okay, so the question says, you notice that a patient is holding their breath during the exertion of the short arc quads or something, or the isometrics. What would be the rest of the question? What's your response? How do you proceed with treatment? Good. Give me an option.
Call the PT.
Okay. What's another, Raul?
Call the ambulance.
Okay, let's be a little more difficult. What's another one, Jackie?
Stop the exercise.
Stop the exercise. What's the right answer? What's the right answer? Please.
To teach patients about the Valsalva maneuver.
Yes. You see how that's going to pop up? So did it matter what exercise they were doing? It didn't. Did it matter what diagnosis they had or how old they were or what position they were in? It didn't. But they probably gave you all that information. But you're like, oh, I see what you're asking, because that's their job to ask you. So if you can read that, like the test writer, you can get in their head and go, what do they want to make sure I know? And then you can actually go, because it's about safety. It's about safety, right? And then beyond that, it's about following the plan of care and getting the outcomes based on whatever healing phase or condition it is. Okay, so let's write another test question. That's great. You see how that's going to pop up? You teach the patient about breathing and not holding their breath. Okay, when do they breathe in and breathe out? During exertion. Let's say they're just doing sit to stands because they're extremely debilitated and it takes everything out of them to do 5. When do they breathe in and when do they breathe out?
Breathe in standing, breathe out sitting.
Okay, so breathe in standing.
Breathe out.
Which is the harder part for the patient to do? You generate more muscle force sitting down, but it's not harder for the patient. They're falling gracefully. They're pulling a Buzz Lightyear. Yeah, they're going to sit no matter if they do it or not. They're going down, right? But yeah, you're right. There's more force. But getting up for them is harder, right? So would you say that that's the exertion part? So do they want to be blowing out on exertion or breathing in on exertion? Exhaling, right? And they're probably not going to do the whole thing in one breathing cycle. So you might say, make sure when you stand up, you're not holding your breath. What if we do that? Make sure you don't hold your breath. So the answer might be coach the patient to be sure that they are breathing out during the exertion. Maybe they can be talking, right? 1, 2, 3, up. Or say anything, you know. Yankee Doodle Dandy, stand up, talk, okay? And that they should take a nice deep breath and out. And then when they sit down, they could even blow out if this is exertion also. You know, if the lowering is really exerting, they could make sure that they're blowing out as well, okay? So that's perfect. So you wrote a question where the right answer was teach the patient the concerns that you're having. Okay, does that make sense? Here's one. You're about to treat a patient for the first time after they were evaluated over the weekend by the PT. You will be ambulating them a short distance to do gait training, which is on the plan of care. Patient arrives to the clinic in the wheelchair by the transporter. What do you do first? Your options are put on the gait belt, instruct the patient the steps that you're going to need to stand up. Like, make sure you have a second person push the wheelchair, or assess the patient to see if they can even do the stand-up today. Ding, 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 winner, winner, chicken dinner. So that's the tricky one. The right answer is not always put the gait belt on. Even though you've been threatened within an inch of your life, if you don't put that gait belt on, you're going to fail. Okay? But in this situation, what was the key word in the question? That you first make sure that that patient is in the capacity to do that activity today. What was important in the question? It was your first time meeting them. It might be their first time walking because they were evaluated over the weekend. They might not necessarily had gait training over the weekend, but it was supposed to start today. So the correct answer is to assess their ability. Excellent. Does that make sense? Don't jump to the gait belt. It's probably not the answer. Okay? Yeah.
So I'm going to throw a little cog in here. Overthinking.
Mm-hmm.
Okay. Shouldn't you have done a chart review beforehand and you would have known what they were assessed at?
Mm-hmm.
So why would you reassess again?
It's the first step in the musculoskeletal PTA treatment. Yeah. And so I think they're going to aim at that. And by assess, it's not evaluate. It's assess at this moment, how are they different than they were Saturday? So it's the PTA assessment. Mrs. Jones, how are you? Do they look okay? Do they look like, has anything changed? I guess we could also say check for changes. Exactly. You check the chart first Has anything changed since Saturday? Are the orders still valid? Because maybe since the PT saw them, something has changed. So chart review would come in before the physical assessment. Make sure that their vitals are stable. Yeah.
Don't add things to the question.
Exactly.
Oh.
That's the reason I asked the question, because I know these guys and
Yeah.
they will overthink it. Thank you, Rebecca. They will overthink
Right.
it. I was testing you. They will overthink it and say, well, I did it, even though it's not in the question.
Yep.
I did the chart review, so I saw that they were already a 3 out of 5 on knee extension. They were able to do a sit to stand with mid assist. So the first thing I'm gonna do is go to gate belt on them. But that's the whole reason I asked you that question.
Yeah.
Because do not assume anything.
Right.
Like what she's trying to teach you is just read the question.
Right.
And go with what's in the question.
Right.
Do not add anything into it.
Right. Now, had there been an option for review the chart for any changes in orders or status, that would have been more correct. But that wasn't an option. Okay?
Sorry, didn't mean to.
No, that's perfect. But that's perfect. So if the one you're looking for isn't there, then obviously you go with what's there. But if you realize they're asking you this to ensure safety and that you can manage the clinic and you already have an assumption of what could go wrong in that treatment. So let's think about your systems man and what could go wrong in that treatment. Let's look at some things that affect the skin. So we've got colostomy or fistula. What could go wrong in that treatment? What do you need to be thinking about, regardless of their diagnosis, when this is existing? What do you think of? Colostomy, what do you think of? Of what? Yes. And what are you doing that would break the bag? The gate belt. Darn gate belt again. It's nothing but a hassle. What do you do if they have a colostomy right where the gate belt goes? Put it higher. Would the correct answer be don't use the gate belt because it could interfere with the colostomy bag? Not if it indicated that the patient should have a gate belt. Right. So knowing that, right? What about a fistula? Who typically has a fistula? Any idea? People who are on renal dialysis, hemodialysis, and they have that big old fistula there, which is that direct connection right between arteries and veins. What does that have to do with you? What do you have to be cautious of on the arm that has the fistula? Blood pressures. Just little things like that. So what would be in the question? You know, you're about to take vitals on a patient who just came from hemodialysis. What are the things you might want to consider? And maybe one of the options is be sure to take vitals from the arm that doesn't have the fistula, right? Just things that seem obvious, but it's like you don't need to miss that one, okay? So let's look at the one that you tried to inflict upon your classmate, dementia or TBI. So let's say there's cognitive issues. How does that impact your treatment? And what do you think the question is going to be about?
Like how old they are mentally, or just kind of where they are in general.
Okay, so let's look at the elderly Alzheimer's dementia. Okay, how is that going to impact your treatment?
They might forget, so you might have to use like things like pictures or things they already know.
So what the question will not be about how many sets and reps you did. It's going to be about how are you giving information. And so what is the main important factor that you would want to include if this is a big part of the
Verbal type documents.
better? Yeah, but there's even better than that.
Tell the family.
You can't rely on the patient for anything. You have to make sure someone else is told, right? It's good to give them the pictures, yes, but you need to be training a caregiver. Okay, so I have a funny story. This is, you want to talk about a fail. I was working at a nursing home, and this was like the best, cleanest nursing home you could eat off the floors. It was run by Catholic nuns, the Little Sisters of the Poor. Ridiculously well run. The activities director, her mother lived in the assisted living portion. They had assisted living and then like what they call the convalescent. The residents were so well cared for. There was a lady in there with advanced MS in her 30s. She was bedbound, nonverbal. And for the 14 years I worked there, she never once had a ulcer, not one wound in the 14 years I worked there. She was up every day dressed with her little skirt, her Foley bag, her IVs, everything was completely tucked. They had morning mass every day. They had a chapel there, Catholic mass. And her father came in every morning and brushed her teeth. And it was just an amazing place. So the activities director, her mother lived in assisted living. And she was starting to decline. And she was getting dementia. And it was very hard on the activities director to accept this. But she was having back pain. And so she was referred to therapy. So I was providing outpatient Part B Medicare therapy, right? And so she would come in. Oh, this is a nice place, she says. I said, well, come on in. And I was trying to get her on the new step. And I would sit her on a hot pack, and she loved that. And I tried to get her to walk with a cane to unweight the hip, but that freaked her daughter out. She thought I was saying her mother was, it didn't have the reaction I thought. I didn't even think about how that would impact the daughter. I said, it's for her back pain. It's not because she can't walk. So we had to go through that. But anyway, so the woman would come at the door, and she'd be like, this is a nice place. I said, well, come on in. I want to show you something. And I said, have a seat on this bike. Oh, I can't do that. I said, well, let's just sit on it. So she'd sit on it. I'd get her on. And I said, let's just see if it fits. Well, 15 minutes later, she's pedaled, on level 1. And she looks great, does great. She says, oh, I got to go. I'm getting tired. I said, well, thanks for stopping by. And so she'd leave. And the next day, she'd come in. It's like 50 first dates. She'd come in. And she'd be like, this is a nice place. I said, well, come on in. And I said, I'd love to have you ride the bike. And she goes, oh, I can't do that. And then she started to get a little bit more resistant because she was hurting. And so I get her on the bike, and I thought, you know what? I got this. This is way back when digital cameras first came out, okay? We didn't have cell phones. And so I'm like, I'm going to take a picture of her on the bike and print it on my printer. And when she comes in tomorrow and says, I've never been here before, I'm going to be like, yes, you were, right? So I take a picture of her, and she's pedaling. I get it printed out. She comes in the next day, and I taped it right on the bike. So she comes in, and I said, come on in. And she goes, well, this is a nice place. And I said, well, have a seat on the bike. So she sits down. I said, look, you were here yesterday. And she goes, that's not me. And I'm like, wow, Deanna, you are a real loser. Like, she doesn't recognize that she's now 80 years old. That's not the person she remembers. And so I'm like, well, back to the drawing board. Yeah. So the point being, if you do have a patient with dementia, they are not your asset. Like, you can't rely on them to follow through the best pictures or videos or anything. So it has to be the caregiver. And that might literally be the only point of the question. Okay, is education, information passing on. Okay, good. Let's look at, and this is not my area, this is Lisa's area. So when you're talking about neurological questions, let's do neuropathy. That's an easy one. Even I can do that one. When the patient has neuropathy in their feet, what do you think the question's going to be asking you to ensure that you can safely manage their care? If they have this, let's assume it's your typical, and they also have insulin-dependent diabetes. Let's say let's say it's that person, okay? Skin checking. What else? Shoes. Balance. Why? So what other systems do you have to use? What system's knocked out? You have 3 systems. Yes, the proprioceptive, musculoskeletal system's knocked out, right? So what do you have what do you have left? Vestibular and visual. Excellent. So all that you're already seeing, and you get this question, you're like, what's the question? I got this, right? You're no longer freaked out. Another funny story about the Catholic nursing home. The one retired priest had this. He went golfing. There was a little 9-hole, or maybe a 9-hole golf course close to the nursing home. So, he goes down there and he's golfing. He comes back only to find out he has a horrible wound on his foot. He golfed all 9 holes with his car keys in his golf shoes because he couldn't feel them. Yeah, he actually was a little crazy. Yeah. Because he also had some dementia going on too. And the problem is, in that culture, the nuns don't question the priest, right? And so the priest is going to do what the priest is going to do. And he wanted to go golfing, but didn't even know he was golfing on top of his keys. Yeah.
Somebody that had a broken toe. They had neuropathy and they just shoved their shoe on.
Yeah.
They broke their pinky.
Yeah.
They just kept going on like that.
Right. Right. So let's say you're going to put them in a whirlpool because that's what's been ordered for the wound. So what red flags are going up? What are you thinking? I know you guys don't do a lot of whirlpools anymore, but what are the dangers? What are the dangers? And whirlpool, what's specific about whirlpool? Can't feel my feet. Temperature. How are you going to know if it's too hot? You can't rely on the patient to tell you this is too hot. You better make sure that thermometer is in there, right? Or that they check. But you're teaching them how to soak their feet at home. What do you tell them? Get a thermometer. Do the little bath duckies that tell you, hey, this water's too hot.
Still wouldn't do that though. I mean, what about infection with diabetes?
Right, right.
Decreased healing. And,
right. That's why we don't use whirlpools anymore.
Yeah.
But if there's a question, it's not about the whirlpool. It's about make sure you rely on something else to test the temperature and not the patient. Okay, does that make sense? Okay, so let's look at these other ones. So yeah. You know what? Let's do this. Let's go ahead and take 5. You guys have been doing great. Let's take 5, and we'll close up systems man, and we'll come back in 5. Okay?